Cardiac disease, congenital heart disease. Women who have a history of surgically corrected congenital heart disease generally tolerate pregnancy well, but are more likely to have babies with congenital heart disease and should be offered fetal cardiac scans. Acyanotic heart diseases such as atrial septal defect, ventricular septal defect, and patent ductus arteriosus all have a good prognosis in pregnancy. Unrepaired cyanotic heart disease has a very poor prognosis in pregnancy, as does pulmonary hypertension, regardless of the underlying cause. Women with mechanical heart valves require anticoagulation throughout pregnancy, but their anticoagulation should be planned with consideration of substituting warfarin with low molecular weight heparin and aspirin during the first trimester to reduce the risk of warfarin embryopathy. If necessary, warfarin can be used during pregnancy, particularly in the second and third trimesters. Valvular heart disease. The physiological changes of pregnancy may also unmask previously undiagnosed valvular disease. Women with regurgitant lesions such as mitral regurgitation and aortic regurgitation tolerate pregnancy better than those with stenotic lesions. Mitral stenosis causes a reduction in blood flow from the left atrium to left ventricle in diastole, which worsens during pregnancy due to the increased heart rate and hypervolemia. Those with moderate to severe mitral stenosis, valve area less than 1.5 cm square, are at particular risk and may develop arrhythmias, tachycardia, and pulmonary edema. Most patients can be managed medically with beta blockers, low molecular weight heparin, and furosemide as necessary. Surgical intervention is indicated if there is continued hemodynamic compromise despite optimal medical management. Myocardial infarction. Pregnancy increases the risk of myocardial infarction. While atherosclerosis is the main cause in non-pregnant individuals, coronary artery dissection and coronary thrombosis secondary to the hypercoagulable state are more common causes during pregnancy. Management is similar to that of non-pregnant women, except that statins and glycoprotein 2b3 inhibitors such as apixaban should be avoided. Clopidogrel can be given but should be stopped around the time of delivery to reduce the risk of uterine bleeding and to allow spinal anesthesia to be used if necessary. Stenting can be performed, but bare metal stents are preferred because drug-eluting stents require dual antiplatelet therapy that cannot be continued around the time of delivery. Aortic dissection. Pregnancy is an independent risk factor for aortic dissection, and this should be considered when a woman presents with acute severe chest pain during pregnancy. The vast majority of cases in pregnancy are type A, involving the ascending aorta and require careful control of hypertension, cesarean section to deliver the fetus, and emergency surgery to treat the aneurysm. Peripartum cardiomyopathy. Peripartum cardiomyopathy presents with heart failure secondary to left ventricular systolic dysfunction towards the end of pregnancy or in the months following delivery. It is a diagnosis of exclusion made when other causes of heart failure have been ruled out. The cause is unknown, but postpartum cardiomyopathy is more prevalent in women who are older, multiparous, hypertensive, and Afro-Caribbean. It is treated by conventional medications for heart failure, including ACE inhibitors if necessary, and delivery of the baby. Many women recover within 3 to 6 months of diagnosis, but the prognosis is variable. There is a significant chance of reduction in cardiac function in subsequent pregnancies. Now, dilated cardiomyopathy. Dilated cardiomyopathy carries a poor prognosis. If the pre-pregnancy ejection fraction is below 30%, or if symptoms are in New York Association grades 3 or 4. Management is as described as postpartum cardiomyopathy.